several deaf schools, as part of her career. My wife is an ASL interpreter. We met actually at Gallaudet University, which is the only liberal arts college for the deaf in the world. I was actually a student there. I got my master's degree and my doctoral degree there. And since then, my focus of practice has really been with the deaf community, because I have the sign language ability and I have sort of the evaluative interpretation competency to really do work with that community. I've done work for the courts, competency evaluations. I've worked for Florida vocational rehabilitation. We've done consultation. So this is a topic that I have a lot of experience doing presentations, publications. So I want to just kind of talk through or just kind of go through a little bit about some of the considerations and some of the, the finer points of doing evaluations with the deaf and hard of hearing. First thing I want to talk about is kind of why is this important? Why do we kind of want to know this about this particular group or this particular population? Well, keeping in mind we have, ethical principles. We're supposed to have competency. We're supposed to have knowledge of the people that we work with. We're supposed to have an appreciation for diversity and diverse cultures and language. And we're really supposed to be in both evaluation and therapy, we're really supposed to be competent in what we're doing, and that we've had training, we have education, we have a sort of a standard of care or best practice that we're able to provide our clients. And so this becomes very important with the deaf and hard of hearing because there are language and cultural considerations that have to be looked at. I'm not going to go through all this, but again, just to kind of, go back into the idea of our professional standards, our competency issues, we do have as part of our profession, and again, I mean, that this is specifically for psychology, but if you looked at social work, counseling, I mean, many of these things would be the same. I have the, school psychology up there as well. But we do have, standards for should be the boundaries of competence that we are able to provide our clients, whether it's evaluation or therapy. The idea of the use of assessments, when is it okay to use an assessment? How do we sort of evaluate, are we able to do this? And what are the things that we should be considering before we decide or before we agree to do an evaluation of a particular client or a client from a particular group? And so these things become very real because they are related to our profession and they are related to the standard of care that we want to be able to offer our clients. So I do want to just give a very, very brief introduction to deaf culture and American Sign Language. Again, this is not a class that would go into this in a lot of depth, but just so that everybody kind of knows where we're going when we start talking about evaluation, I just want to get into, some of the basics of it so there's some understanding. And when we talk about deafness or we talk about deaf culture, we've seen changes over the years. We've seen it, kind of shift from a very medical model where deafness is looked at as an impairment. Deafness is looked at from a sort of a disability model to where deafness is really looked at more from a cultural model or a cultural perspective. And so one of the things that's kind of developed from that is that at the deaf or deaf people or deaf culture has really been seen as a minority group and in a lot of similarities with other minority groups that we have talked about or may learn about. And again, the deaf community focuses on socio-cultural aspects, but this is very similar to what other groups do. I mean, other minority groups also have sort of a basis in culture, whether that's religion, ethnicity, but there are social cultural aspects and norms that we see from that community or based on that culture. Tend to be a sort of a positive self-identity, and that can come from culture, the language, the shared experiences, but there's an identification with that group. There's sort of a positive spin on that group as opposed to a negative or an outside perception. And we do see that, people, just like other minority groups, in a hearing environment or in a different cultural environment, we might see people be more passive and withdrawn, where when they're in their own environment or their own cultural community, they may be more active and involved. And again, all these things are very similar to what we see in other minority groups. And you could apply these to other minority groups, again, based on ethnicity, race, other types of diversity. And this becomes, again, it's important to sort of look at as you conceptualize, okay, how am I going to do this testing? How am I going to do this evaluation? One of the things is that, how would we approach this with another minority group? When we look at doing evaluations with different groups or diverse or minorities, we have to look at how can those things that related to culture, related to language, how can those things affect the psychological evaluation that we're doing? And in the same way, we want to look at and appreciate what are the things that I'm going to need to do, maybe do differently, maybe do additionally, maybe do less, that are going to provide a good, thorough evaluation for somebody that comes from the deaf community. And that's what we should be doing for all minority groups. I mean, we should be looking at all groups that are different from us or different from the norm. As when I conceptualize the evaluation, how do I need to approach this in a culturally competent way? One of the one of the things that we also need to talk about, because this is going to have a very profound effect on how we do an evaluation, is the idea of American Sign Language. Being that American Sign Language is based on signs rather than verbal or auditory cues, this is something where it's going to affect our testing. This is something where right away we know there are going to have to be accommodations, or we're going to have to put some thought into how are we going to approach this when we're using a language that is very different from what any test was really designed to do. So just a few kind of basic things about American Sign Language. It's the third most used language in the United States after English and Spanish. It employs signs made with the hands. But it's also really important to note that a lot of sign language is really made with movements of the body and face. And a lot of the facial expressions are almost overpronounced because they do give cues to what the person is saying. There may be, in the English language, there's a lot of signs for the concept of sadness, depression, melancholy, blue. Sign language might be rather limited. And again, we have one, maybe two signs that represent those things. So we kind of show the meaning. How deep is the depression? How strong is the anger based on the facial expressions, based on the movements of the body? So that becomes a very contextual way to understand what the sort of the tone of the conversation is. Or again, if you're doing an evaluation, are we talking about somebody that's a little depressed? Or are we talking about somebody that's having a major depressive episode or experienced trauma and is reliving it at the time? So, those movements of the body and face are very important to note and very important to notice, as opposed to just sort of seeing sign language as, well, it's just something done with the hands. Also, it's important to note that American Sign Language is distinct and independent from English. It's two completely separate and different language systems. American Sign Language has its own rules of grammar. It has its own rules of production and structure that don't necessarily mirror the English language. And again, just kind of going off that, there are a lot of different sign languages around the world. There's French Sign Language, there's Spanish Sign Language, there's British Sign Language, or BSL. Well, English, American English and American or British English are fairly similar. British Sign Language and American Sign Language are very different. So you have to kind of understand, what is the language or the change in language? How is that going to affect the testing? How do we take something that was written for really a verbal English administration? How do we use that in an ASL format? Keep in mind that not every deaf person uses ASL or signs at all, and that's a consideration we have to look at. That, just because we have a deaf client that we're doing an evaluation, that client may or may not know American Sign Language. They may, they may know Sign Exact English, or what's called Pidgin Sign Language, or they might not have any sign language at all. And again, what type of adaptations do I need to do? What type of considerations do I need to make for testing? Those are going to be based on, okay, well, what language will I be using, and how much of that language is this person going to understand and be able to access? So another thing to keep in mind is that deaf is not a single variable. And if you kind of look at the little graph on the right, we kind of see that there's a lot of variations in deafness and deaf culture. There's sort of the big D deaf, which is the sort of the deaf culture representation. There's a small d deaf, which the lowercase d kind of represents the condition. There's sort of the prelingual deaf, people that became deaf before they learned to speak and have never been exposed to an auditory form of language. There's the term hearing impaired, which, is not looked very fondly upon by the deaf community. It over focuses on the impairment instead of the culture. There are people that become, deaf late. Either, they've lost their hearing as a result of an accident as an adult, or as a, result of aging. And there's also people that are oral or speech reading deaf, that they don't use sign language. They prefer to read lips. They prefer to read speech. And again, my presentation is really about those people who are deaf that sign. But, that is an important consideration, and that is something that you would want to know, before starting an evaluation is which of these variations am I going to be working with? Who exactly is the client I'm working with, as opposed to just saying, well, this is a deaf client and they're all the same. Causes of deafness, there's genetic and non-genetic causes. So, I mean, that could be a factor. Sometimes the genetic causes have other factors that go along with them that can also cause conditions that may be of concern in evaluation. Family reaction to deafness. Does the family sign? Did this person go to a school for the deaf, or did they go to a mainstream school for the hearing? Did they have any socialization? Were they around other people that they signed with? Were they able to have, sort of normal peer and social relationships? And again, the patterns of onset, when did the person become deaf? What is the extent of the hearing loss? Again, there may be something different between a person that has almost no hearing and somebody that can hear the hearing losses, is not that severe in terms of what they're able to do. When did they develop language? And we see differences between people that develop language early on and those that develop language later. Just like in English, we see that also in sign languages. Also, the development of the personality, based on peers, based on family situations. What are the educational needs, the assistive technology needs of the individual? What are their preferences? And then, in terms of what has been their social interaction up to this point. And that, again, it's going to have an effect on, okay, well, what tests are going to be the most appropriate to use for this person? How am I going to administer these tests in a way that makes sense and is understandable? And then how am I going to interpret the results, especially if I'm having to break protocol, if I'm having to administer the tests in a way that was different than they were designed for, in a way that I'm sort of getting results back from the person. Those are all things that I'm gonna have to look at as well. How much does that affect the test? And what do I do with those? How do I talk about those things in terms of this is not going to be the same way or the same interpretation that I would make for someone else? Just a little bit on the current state of mental health services for the deaf. We really don't have a lot of research. I mean, that's probably something where if you have a research interest on something related to some type of mental health service or mental health intervention, it probably hasn't been done before. And if it has, it probably hasn't been done for a long time. So we don't know a lot about the deaf community. We're getting better. There's more than there used to be, but there's still a lot of gaps. And again, meaningful research, a lot of the early research was done from a very hearing perspective. It was sort of outsiders looking into the deaf community and saying research and telling the world about the deaf community from their perspective. The more meaningful research is really coming from the deaf community themselves. And again, we're sort of looking at ourselves as insiders as opposed to somebody from the outside. Lack of accessible health information. Certainly, health information is out there. The question about accessibility is it really designed to sort of interact in an accessible way with people who are deaf? Reading levels, captioning, the idea that, we have an environment that is suited for somebody who's deaf to come in and get services. So, how are these things accessible and how do we communicate that information to deaf adults and parents of deaf children? And then very underserved in terms of appropriate services. There's a lot of services out there again, but just like meaningful research, we have to look at appropriate services. And then we start to get into, okay, the idea of competency, who's really competent to provide these services, and what are the accommodations or changes we might have to make, as a result of giving these services, providing these services in a sort of a culturally competent way. One thing we want to think about before we start looking at the evaluation or actually doing the evaluation is, we have to be careful about assumptions about deafness. And we already talked about one, which is that all deaf people are the same. It's just a single group. And we kind of already know that there's a lot of variations within that group. We also don't want to over pathologize deafness. As we sort of approach or conceptualize an evaluation, we want to look at, are we sort of pathologizing something or putting pathology on someone else? And a lot of times people will sort of look at, again, people that don't know a lot about deafness who are mental health professionals, they'll sort of take the approach of how could a deaf person not be depressed? How could a deaf person not be anxious? Just by the fact that you are deaf would sort of suggest that there's no way you could be psychologically healthy. You have this disability, therefore you'd have to be depressed about it. You'd have to feel different. And again, we want to be careful about that because that certainly is not always true. And so we don't want to make that assumption. We also don't want to look at that the deafness is the reason the person is getting services. It's not necessarily a question of the deaf person wants to get an evaluation simply because they're deaf. The deaf person doesn't want to get therapy just because they're deaf. Deafness may have nothing to do with the reason why this person has services. And again, we have to be careful about imposing that on the person. Limited capacity. And again, we have a lot of negative words associated with deafness: disabled, handicapped. And again, the suggestion is this person can't do it. This person cannot do it the way a normal person would be able to do it. And so we sort of put these limitations on the person rather than looking at the individual in terms of what they can and can't do, which, by the way, we should be doing with all clients. And then again, the sort of the needing of help and sort of the needing of help from the hearing world, that deaf people can't do it on their own. They can't do it by themselves. And so we kind of have to be there to help them along. And again, if every patronizing and pathologizing sort of aspect or view of deafness that very often is kind of looked at, or these assumptions are made. And again, the idea, traditionally has been on the focus on cure and correction of deafness. Deafness is bad, deafness is wrong. So treatment has been based on, well, how do we make the deaf person more hearing? How do we sort of, make them more fitting into the hearing world, as opposed to really looking at concerns they might have, or issues they might have from their perspective and where those things are coming from. And sort of the assumption that people who are deaf want to be more hearing. By making them more hearing and fit into a hearing world, that's going to lessen psychological phenomena, mental illness, stress, all of those things, because now they're sort of in that hearing world. And again, we have to be careful of these assumptions because they're certainly not always true. And a lot of times these are things that mental health professionals, we impose on a deaf individual or a deaf client, rather than looking at them in terms of how they see themselves and what their needs are. It's also important to remember Alan Sussman and Barbara Brower, who were both deaf psychologists at Gallaudet. Both were former professors of mine. Did a lot of research in the late 90s. And again, some of their research was the first research done from a deaf perspective rather than a hearing perspective. And one of the things they found was that there are vastly more well-adjusted, psychologically healthy, and effective deaf people than not. And when we look at the deaf community, we look at the vast majority of people in the deaf community are psychologically healthy and fine and don't need our help and don't particularly need anything. So we won't want to overgeneralize. We want to remember that most deaf people are doing just fine without our help. So we want to focus on the individual that's coming in for evaluations, not generalize it to an entire community or to an entire culture. So what are some of the things with psychological evaluations of people who are deaf? And we have to look at this as a challenge for psychologists. I mean, even with psychologists that work with the deaf on a routine basis, there are still a lot of challenges. There's still a lot of things that we don't have. And again, you could apply that to other minority cultures as well. But one of the things we have to acknowledge is that, this is the best we've got right now. And that doesn't mean we can't improve. That doesn't mean we can work towards, better research or better assessment techniques. But, we have to work with what we have had at the time, or work with what we have right now. And we have to kind of keep in mind that there are going to be a lot of adjustments. There are going to be a lot of accommodations. Things aren't going to be perfect because they weren't designed for this population, but we still have to work within those parameters, that we still have to do the testing and administer testing and score testing and interpret testing based on scientific principles, even though those principles could be better applied to people who are deaf. So challenges, some of the challenges are, there's a lot of apprehension of hearing psychologists by people who are deaf. You can't communicate with me. You don't know anything about my community. And so how do I really know you're doing this correctly? How is it, when I don't even, I'm not even able to communicate with you, or when you're not able to communicate with me, how do I know that this is going to be a fair evaluation? Misinterpreting culture as evidence of pathology. And again, in sort of the past traditional way, it's sort of looked at as, deaf people are different from hearing people. And so deaf people were based on, or evaluated based on, what is normal for hearing. And so we've seen a change come by where now we're really looking at, okay, well, there's normal versus normal for deaf. And we have to move away from comparing, the deaf community or people within that community or culture to a hearing population, but looking more comparing to is this normal for their population? Is this normal for the deaf community or deaf culture? A lot of times we find that people who are deaf might have limited knowledge of personal or historical information. 90% of children who are deaf are born to hearing parents, and in many cases, most cases, those parents don't have any sign language ability. There's very limited communication, both at home and quite possibly in school. And so when you're asking somebody about their personal or historical information, they may not have it, not because of a cognitive limitation, but again, we tend to learn about our family history. We're sitting around the dinner table. Our parents tell us about that. Our grandparents tell us about those things, what we were like as children, what our family history is. Well, if we don't have that communication with our parents and family, if we're, going to a residential school for the deaf, we may be missing that information. And so it's not unheard of that you will have some deaf people who don't have that information because it was never communicated to them. Knowledge of current situation might be limited by accessible explanation. The person that brought me here to do this evaluation, they didn't know sign language. I was simply told to go with somebody. I was simply told to go to this office, and then somebody showed up, and I really don't have any idea why they're here. And again, when we ask people the question, can you tell me a little bit why you're here? We find it kind of puzzling that the person really doesn't have an understanding. And again, there may be good reasons for that, but in the case of someone who's deaf, there may be a very concrete explanation. Nobody told this person, and nobody told this person because in the group home or in the hospital or in the school, nobody knew sign language, and so nobody was able to communicate with that person. And again, that's a very different person than somebody who had been told that information and can't remember it or doesn't understand it. A lot of times we see frustrations with communication during evaluations. Again, either I'm signing or somebody non-proficient is trying to sign. I'm using a friend or a family member as an interpreter. The ASL interpreter isn't getting things correct, or I'm trying to explain something to you and you're just not getting it because you don't know sign language or you don't know sign language well enough. And so again, a lot of frustration, not sort of, that's a sort of an anger management or a control problem, but I can't communicate with you and it's frustrating. There's things I want to tell you, there's things I want to say, and I'm not understanding it. Or there's questions you're asking me, and I'm not able to answer that question because I don't understand what you're trying to ask. And so again, we have to be sensitive to kind of recognizing, where is that line? Where are these frustrations coming from? And a lot of these things, which are very normal or can be very normal for someone who is deaf, can be misinterpreted. And they can be misinterpreted as noncompliance, anger, avoidance, paranoia, immaturity, socio-emotional difficulties. They appear to be those things, but when you really break it down and look at it from a cultural perspective, there's a reason for it. And it's a reason that doesn't necessarily have to do with pathology or impulsivity or some of the other things that we tend to diagnose or use for a diagnosis. So again, it's really kind of important to understand the cultural aspects and where some of these behaviors are coming from that perspective. Some of the more specific challenges and consideration in testing, language. Like I said, there are some deaf people that don't use American Sign Language. There are some people that don't use, any language at all or have no formal language. So one thing that we need to consider is, does this person have language? And again, there's American Sign Language, and then there's also different forms of sign communication, signed exact English, pidgin sign language, cued speech, things like that. Those are not languages. They're kind of more based off the signing of the English language. So we have to look at, is this a bona fide language? Is this something where there's communication, or is this something where the person is really nonverbal? And we do get people that, they're deaf. They didn't go to school. They didn't get any kind of education. They were in a hearing environment where there was no real sign language, and they really don't have any language. Or their language tends to be very gestural in terms of what they're able to do. That's going to be a very different person, or those are going to be very different persons that I have to conceptualize. Well, how am I going to give this person a test? I mean, at least I have to explain to the person what they're expected to do. So how do I do that? How do I kind of conceptualize that in terms of what are the things I need to do that? If we do have somebody with a primary language or a good form of communication, we really have to look at, okay, well, what is their ability level? You know, when we talk about people in terms of reading and writing and knowledge of the English language, we tend to focus on, okay, well, what are they able to do? What is their sort of their grade reading level or their age reading level? And we kind of, have to customize testing to, okay, well, what is that level that they're able to do? And in addition, we may need to do the same things with somebody who's deaf or hard of hearing is, well, how much do they know in that primary language? Is this something where I can just sign to the person just straight? Is this something where I have to bring in a specialized interpreter? How am I going to get this communication based on that person's communication or language ability level? And then the use of interpreters. And I'll get into that a little bit later, but that is something where I have to consider, is this something where I am comfortable and competent in signing directly to this person and having two-way communication, or is there something about this person's language where I need to bring in an interpreter? And then we have to consider, okay, well, if it's a testing environment, when I bring in an interpreter, how does that change the testing environment? How does that accommodation sort of shape the way I'm going to be administrating, scoring, and interpreting the testing when I'm not actually the one directly communicating with the client, and the client's not necessarily the one who's directly communicating with me? We also know that reading tends to be a problem. If you think a lot of the tests we do, especially more of the achievement tests, but even some of the personality tests that we do, the self-reports, there is reading that has to be done. And typically that reading is going to be in English for most of the clients we have, or Spanish. But we also know that for your average deaf person, that reading tends to be usually a few grades below where we would expect it for somebody that's hearing. Now, that does not mean that deaf people cannot learn to read at a proficiency equal to someone who's hearing. There are deaf attorneys, there are deaf lawyers, there are deaf writers. I mean, it's a question more about, what was their education, what was their social background. But that is something that we have to think about. What is this person's reading level? And knowing that, this is a second language, or English is a second language for this person, and quite possibly if we're talking about somebody who's prelingually deaf, they may have never heard English or any other language for that matter. So we have to start thinking about, okay, well, based on that, what test can I give this person? We have to start looking at, okay, what is the reading level of the test? Because if we're giving people tests that require reading at a level they can't do, we're kind of wasting everybody's time, and we're going to get very bizarre and very, misdiagnosing types of information. So read and respond types of questions, self-report, objective measures, we really have to know and understand what is this person's reading level of English. And that can be very different from their mastery of ASL. You can have somebody that communicates with, ASL fluency, but their reading is about fifth grade. And that's not uncommon to see. So you really have to kind of base that on what am I looking at and how do I test to make sure that I'm using the right tools to do this type of assessment. English to ASL translations very often are problematic or a challenge. Some words, English words, don't have a signed equivalent. Again, English and ASL, they're not mutual languages. They're not just sort of a signed version of one or the other. So, some of the things that, we have to think about, when we talk about, on the MMSE, there's a 3-word task. I'm going to say 3 words. I want you to remember them and say them back to me later on. Well, apple, table, and penny are an example of one that was used. There's a sign for apple. There's a sign for table. There's not really a sign for penny. There's 1 cent. There, I could fingerspell penny, but now I've changed the nature of the test. Now, if I use 1 cent, now it's 4 words. It's not 3 words. If I fingerspell it, now it's a spelling test. And I don't know, maybe that will be an issue in interpretation. Maybe that will be an issue in scoring. Maybe it won't be. But you have to consider it, and you have to think about, and you have to look at, is this something where it changes the test too much, or I have to interpret the responses a different way? Yeah, they didn't score that wrong, but they did score that wrong, but one of the reasons they scored it wrong was because of the way I administered the test. And so that, we have to be sensitive to and try to understand. Some words, terminate, for example. I mean, there's sort of end, or there's finish, there's stop, but terminate. I mean, does last or end or finish or stop, is that the same as terminate? So again, how do I do that? How do I sort of look at, are those things equal? Does it make sense, the sign that I'm using? Does it make sense, the sign that the person is signing back to me? There also could be meaning confusion in terms of, well, what word is the correct word to use, or what word is the correct response for the sign right, or the word right in sign language. There's right, which is sort of a right answer. You got the question right. There's right, which is sort of a right turn. There's sort of it's all right, it's okay. You broke something, but it's all right, don't worry about it. And then there's more of a legal right. You have a right or a constitutional right. Sometimes it can be confusing. Well, which one do I use? Which one is the client actually signing? Do they actually know the word, or are they getting it confused? I do a lot of forensic work, and we have the Miranda warnings. The first sentence of that is you have the right to remain silent. And you'll see sometimes interpreters have a really hard time because they're not as familiar with it and sort of the overall meaning. Which word do I use to convey the concept of what that means? Other questions, I often feel downhearted and blue. There's no way to sign that with an ASL equivalent. It just doesn't make sense to do it. If you were to sign it in ASL, first of all, the sentence wouldn't make sense, but then it would sort of give an indication that my heart has kind of dropped somewhere into my stomach or my rib cage, and my skin has turned blue. But there's not a way to convey that with that same undertoning. There's a sadness there. There's a melancholiness going on. And so that gets very difficult to do because there are no words that are really the equivalent. I know we talk about and we see finger spelling a lot. The manual alphabet. We all probably at some point have learned to finger spell or learned about finger spelling. Finger spelling kind of has a weird relationship with American Sign Language. It's not really part of a typical ASL conversation. Deaf people don't spell to each other. Think about it. Try going and have a conversation with a friend and just spell everything. It would drive you crazy. It just would be too confusing and too taxing. So finger spelling as part of American Sign Language is really only used if there's a word where there hasn't been a sign sort of connected to it yet. A lot of times in technology, the technology's ahead of where ASL is. So until there's a sort of a mutually agreed upon or established sign, a lot of times there'll be sort of a finger spelled word for it that's kind of a temporary or kind of a placeholder. But finger spelling is not something that really is a substitute for American Sign Language. It's not something where if I'm going to be doing an evaluation, I'm not going to finger spell the instructions of what the task is. That doesn't make any sense to do. And again, just think about trying to get instructions in sort of, a spelled way. It'd be very hard to follow. It'd be very hard to understand, and it would be very taxing. So that's not just something you can rely on and go, well, I don't know signs, but I know how to finger spell, so I'll just do this evaluation in finger spelling and everything will be equal. It will not be. Cultural context is often sort of seen as pathology and, based on responses. If you think about the MMPI or the PAI, that's sort of the objective types of measures of personality, a lot of times there are questions that, have to be responded to. There are first choice response. So yes, no, true, false. But sometimes these questions, even if the person is able to read it, sometimes they're interpreted differently. So a question like no one understands me, which could be sort of the psychosis, people don't understand my the delusions I'm having, or the things I talk about, the derailment. Could be sort of a teenage angst kind of depressive kind of thing. But for a deaf person, it's actually true. No one does understand me. I mean, it could be if I come from a hearing home and I go to a school that's a hearing community school, and all the people in my neighborhood are hearing. Well, that's not depression. That's not pathology. That's just the way the world is. The problem is the algorithm doesn't know that. And so it's just simply scoring things based on what a yes answer is without taking culture into consideration. And so you can have people scoring, or factor loading on things that may not be realistic. I have often felt that strangers were looking at me. Well, yeah, when I go out in public and I'm signing with my friends or family, yeah, people look at me. So again, that's a very real thing. I'm bothered by people on the outside streets and stores watching me. Well, again, it does bother me. I'm trying to have a conversation with my friend in sign language, and I kind of see out of the corner of my eye, there's like 3 or 4 people just standing there staring at me. Yeah, that does bother me. But again, that's not paranoia. That's a real event. So we have to be careful in how we're sort of interpreting, and in this case, how the algorithm for the MMPI or the PAI or one of those tests, how that's interpreting it versus what did the person really mean. With just some stuff on, neurocognitive tests, and I kind of threw those together, even though they're different. But for the points I'm making, I'm putting them together. You can still do neuro and cognitive testing, but you really have to interpret with caution. You really have to look at, am I following the protocol? Am I following standardization, or am I breaking with it? And by breaking with it, what am I doing? What does it mean when I do that? And that's why it really requires a competent test administrator, somebody that really has experience, somebody that really knows, by accommodating this, by changing this, or by doing it the way I'm supposed to be with somebody who's deaf or using ASL, I already know I'm going to get answers that I have to be very careful about how I talk about. So again, you can do these things, but you really have to have that knowledge and that understanding to know what you're interpreting. Challenges, we already talked about vocabulary and spelling tests. A lot of times shapes might give away the correct answer. If I'm asking you to identify an airplane, well, sometimes, I mean, again, the sign kind of tells you what it is. So those are things to consider. Number letter confusion, especially if you have somebody that is signing it without a great degree of sign language. Some words can look like, or some signs can look like numbers. They can, kind of be mistaken for numbers unless they're clarified. So again, if the person's not signing them correctly, back versus front, that little nuance there, then it could be taken as, sort of a wrong remembering of a letter or a number in that sequence. Time verbal response test. I can give a time verbal response test. Let's say you have a minute to name everything that starts with the letter D. I can do that relatively quickly. I mean, you got a minute to do it. I don't have to be looking at you to do that test. If you're hearing, I can look down and I can be writing your responses. With somebody who's deaf, I have to be looking at them to see what they sign. And so potentially, if I'm having to look up to see the sign, and then I'm having to say, hold on, so I can write it down. Okay, do the next one. Well, how is that affecting the time? And again, we have to be very careful, because I can say, yeah, that's affecting the time. That's costing this person being evaluated, that's costing them an extra 20 seconds, let's just say. Well, do I know it's 20 seconds? Do I just add, so instead of a minute, they get a minute and 20 seconds? Do I just simply say, okay, this person is probably going to score 10 words less than your average hearing person? Do I have any evidence to back that up? And so again, that's where it gets really tricky in terms of, okay, well, what do I do? How do I adjust this? Should I adjust it? And then what do I do with the interpretation of the scores? Role of incidental learning. If you think of some tests, that require sort of, an identification of something, a picture, a concept, kind of learn knowledge, or knowledge that was picked up, like for an information subtest. One of the things that we have to remember is that for hearing children, they're always learning new things. They're always being exposed to things through hearing. So I can be in the living room, watching TV, listening to the radio, doing my homework, and hearing my parents talking in the kitchen, and I'm still getting all of that information. I may have to sift through it a little bit, but I'm still exposed to all that information. I can be, someplace, and the person sitting next to me has a radio on, or a phone that they're, talking to, and I'm still hearing or learning from that conversation that they're having. As a deaf person and as a deaf child, I really have to be facing the person. Now, there still can be incidental learning. I'm not saying it doesn't happen, but again, it's much more restricted, because unless I'm looking at the person or I'm looking at the event, I'm not getting that information. And so we might see some differences in some of those informational incidental learning types of scores. We talked about verbal scores tend to be 2 to 3 points lower than that of hearing pairs due to English versus ASL challenges. Again, they might not have the English word knowledge, and so we want to look at, is that permeating towards their knowledge of ASL, or is this really just something because it's a second language and the skills in English are just weaker? And what does that mean in terms of what are we trying to do? What are we trying? Are we diagnosing? Are we looking at achievement? Are we looking at general intelligence? How much does that 2 to 3 point difference really mean in terms of what's the referral for? What am I going to do with the information, and how do I report it? Perceptual reasoning, I'm kind of focusing a little bit, more on, the waste, but, perceptual reasoning, memory processing, they're generally equal to hearing pairs. But the caveat to that is you have to have a competent test administrator. Even though you're dealing with, sort of nonverbal types of tasks, we still have to explain what they're supposed to do. And then, once we do that, we still have to interpret the scores they get. So it's not just something I know we kind of talk about where you can just kind of stick the stimulus book in front of somebody, just kind of point, and they'll figure it out. Yeah, maybe. But to really get a good score, there should be some instructions. There should be, some what am I supposed to do with these blocks? What am I supposed to do with this picture? And when you have somebody that's able to, to provide that information and kind of understand, what the person is doing, yeah, those scores are probably going to be equal to somebody hearing. We also have tests of nonverbal intelligence. I'm not a big fan of them. They're good. They're used. The Tony 3 and the C Tony. I mean, that's nice because they do have some norm references. They're sort of non-linguistic problem solving. They're sort of, a lot of matrix reasoning. Here's a pattern, fill in the last pattern. They're good. I mean, they can be used. I think they're very limited, though. I think you don't get a lot of information. I think there are better ways to get information on sort of, intelligence and functional intelligence than just kind of doing, it basically is one subtest in sort of different patterns. Some people do it. Some people, sort of will use that as a test or at least an estimate of somebody's intelligence, a deaf person's intelligence, which I think, again, is an estimate. I think that's fine. But I think for a lot of testing, you're going to want to dig a little bit deeper and to not just sort of say, well, I mean, this is a test for nonverbal intelligence, and I don't know sign language, and I don't want to bother with an interpreter, so I'll just give this and I'll just kind of point and hope the person figures it out. That's not a good standard of care. That's not a best practice. And again, we need to be a little bit more attentive to that. Are we really doing the best job for the client, or are we doing an adequate job because that's all we know how to do? Oops. So personality assessment, we really don't have a lot of norms. Right now, I'm kind of working on doing some norm referencing with the MMPI 3. So we're going to start some of that research, hopefully by next month. So we'll have some data on that. But generally, we don't have a lot of norms on objective testing. The BDI, the BAI, MMPIs, things like that. The problem is that there's a lot of misinterpretation that can happen by either, underreporting or overreporting, sort of related to actual pathology. And again, we talked about this a few minutes ago, but these tests are scored on an algorithm. A certain amount of trues or yes means something. It elevates a score. The problem is a lot of these tests don't take in context or culture. And so you might have somebody for, yeah, people, don't understand me. And of course, when they hit yes to the answer to that question, the algorithm is kind of, it's moving it onto something without knowing that there's a reasonable explanation for why that person is sort of saying true that doesn't have to do with psychopathology. Also, some questions don't make a lot of sense. You think about hearing voices. Is that going to be read the same way by a deaf person as by a hearing person? Is that going to mean the same kind of thing? Is it going to be interpreted the same way? So we kind of have to look at, what are the actual meanings of how people are responding. Reading challenges and self-report measures, same kind of thing. Is the person able to read it? Projectives, again, we don't have any norms, and sometimes it's difficult. When they sign, what the ink blot looks like, how does the sign they use translate into, is it a whole? Is it a part? Is it white space? Is it something else? Some of that can be very difficult. Also some signs, fish is a moving sign. Butterfly is a moving sign. So it's something where, are they saying that the ink blot is actually moving, or are they just using the sign for it? And so that can be, again, that's a big difference in terms of the Rorschach, but it's hard to know that. Symbolic gestures that are cultural responses kind of look bizarre. And I have a sort of a picture of a past client or a past kid that I tested. And one of the things that you can see is he drew his family. They have ears, and they have their hands behind their back. And that was his way of drawing that his family is hearing and they don't sign. And he drew himself with no ears, and he drew these very, kind of big overpronounced hands. And symbolically, what he's showing is he is a deaf person. He has ears, obviously, but he's not hearing, and he uses his hands, and his family doesn't. And again, if you don't know that, if you don't understand that that's a very, that can be a very typical symbolic representation, you're going to look at this and think there's something really weird going on. The family's hiding something from him, and he's unaware of it. I mean, there's a whole bunch of ways you can interpret this, in sort of a, projective Freudian psychodynamic way. But It's none of those things. He's just drawing kind of, this is who I am, and this is who my family is, and this is who my parents are. So we got to be careful again of how those things look. Risk assessment, we don't have any really specific norms for doing risk assessment. We don't really have any meaningful studies on reoffense for offenders who are deaf. So we really don't know what are the big factors that, are likelihood to persist in crime. What are the factors for a deaf person that lead to reoffense versus what are the ones that mitigate reoffending? So we really don't know, for risk factors, what it is we're actually testing. What are the factors we want to be looking at? And then again, instruments based on these factors, they may not accurately assess risk because we don't really know what are those risk factors. Sexual attitudes, behavior inventories, again, no specific norms. So we're seeing this pattern again and again and again. When asking questions about sexual behaviors, we kind of need to know about culture. How does the culture sort of look at sexual behavior in terms of what is appropriate and what is not appropriate? How did the person learn about sex? I mean, most of the time we learn about sex from our families, our peers. We might learn it in school. We might have, religious or ethnic or cultural, sort of discussions about what is appropriate sexual behavior. Well, if this person doesn't have communication, I mean, that may be something where, information on healthy, normal sexual functioning was never translated or never provided to them. Every deaf kid goes through puberty, but not every deaf kid may have the communication about what is that like, how does that happen, what are appropriate ways to deal with sexual urges and arousal. And so that has to be something taken into consideration as well. Sexual terminology and sign language, again, that going to have to do with familiarity of signs. I mean, there's a lot of signs, and again, sign tends to be very iconic. It tends to be very direct. And so it may be that the way a person is signing, it might indicate they don't have empathy. It might be a sort of a very vulgar way of signing a particular sexual act, but that's how it's signed. I mean, that is the sign for it. And so again, you have to be very careful about, is the person signing this in a correct and meaningful way? When they're signing things, does it really sort of, are you able to understand what was going on or what the behaviors were that we're trying to evaluate? We also have to look at, again, barriers to communication and how people function and how people sort of see sex and will report on their sexual behavior. When you think about your own sexual experiences, think about how much you rely on sort of your sense of hearing, your sort of auditory versus what are other indicators of consent? What are other indicators that, you're pleasuring your partner is pleasuring you? Communication about consent, boundaries, indications of pleasure, how much of that is based on hearing versus based on vision or tactile or something else? And again, as you start to think about that, we have to think about, what are those cues? How can sexual positions, how can, being in a dark place, how can that interfere with communication? How can that interfere with, sort of the boundaries or the consent issues? Again, I'm not sort of, coming up with an excuse for sexual abuse. I'm just saying that those are things that have to be considered. What was the situation like, as we start looking at what this person's behaviors were or how these person's behaviors ended up. Just a little quick tangent. We are kind of running out of time, so I don't want to spend a lot of time on this, but there is, sort of the evaluation or looking at people who are survivors of sexual offenses who are abuse. Again, not necessarily from a evaluative perspective, but it is a difficult thing. Somebody who's been sexually abused, who's deaf, it's going to be difficult for them to communicate that. I don't have the ability to communicate, or the police don't have the ability to communicate with me. Can this interpreter accurately, interpret the feelings that I have, the emotion that I went through? It's not just fact, 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 fact. It could be a lot of very heavy emotional contact. And is the interpreter able to accurately do that? If, the sexual abuse victim is female and the interpreter is male, which they try never to do, but it could happen. I mean, again, what's the comfort level there? Is this male going to really understand what those feelings were like, or vice versa? Attorneys, police, judges, juries, family. I mean, this is something where, I don't trust these people because they really don't have the communication. How do I talk to my attorney? How do I make a report to the police? Are the juries going to see me different based on the way I communicate, based on the fact that I'm deaf? Am I going to get support from family and friends? Well, what about family and friends that don't know sign language? How do I communicate some very deep contextual feelings to them? support agencies, treatment, advocacy services. The only way I can get help typically is through an interpreter. And again, now I'm faced with this. I don't really get to speak for myself. It's all being filtered through somebody else. And I really don't know if that person is doing a good job of filtering that information because I can't hear what they're saying. We'll get into this again with interpreters, but there are some rules about you never want to use the abuser or the victim's family to interpret. Again, there are some ethical considerations there, but it's really something where you need a qualified interpreter rather than a friend, rather than a husband, a wife, a spouse, a victim, an abuser to do that interpreting for the sort of the secondary kind of gain types of things. So collaboration with ASL interpreters. The reality is there's just not a lot of signed proficient psychologists out there. There's not a lot of people that can do psychological evaluations. So most of the people that are doing evaluations, I would probably say, most of the people that are here, attending this workshop or seminar, probably, yeah, you're going to need a sign language interpreter. And that's not a bad thing. That's okay. I mean, there's nothing wrong with doing that as long as you kind of know what are some of these other areas of competency. So what is a qualified interpreter? And remember that the interpreter is there to provide effective communication. They're not really there to do a lot of other things. It really should be somebody that's got formal training and a certification. There's the Registry of Interpreters for the Deaf. It's a professional organization like APA or NASP or one of those, but it registers interpreters. It looks at certification. It's kind of the gold standard for at least American Sign Language interpreters. What is not a qualified interpreter? People that claim they can interpret because they had a few sign language classes. I get this all the time. Somebody is interpreting because, I used to interpret at my church back home where there were 3 deaf people and I was the only person that signed, so I'm an interpreter. That's very different than formal training. That's very different than really having professional knowledge. And remember, sign language interpreting training, it's more than just language. It's more than just communication. There's ethical guidelines. There's professionalism. So there's a lot more to it than just, oh, I know how to sign because I took a class once. Family members are not qualified interpreters unless unless they have certification. But especially for divorce, custody, domestic violence, child protective services cases, you don't want to have family members interpret. That really needs to be somebody outside of the family because again, it's you're never really sure, is this person really interpreting accurately what the person is saying, or do they have their own agenda? And just because a spouse, a parent, a child, has a deaf family member, that doesn't mean they can sign. There are plenty of deaf adults who have deaf parents. They can't sign, or they can't sign with the proficiency to be an interpreter. You should also never use other inmates, patients, residents, or clients. It's not their job. They're not trained to do this. And again, they may have some secondary type of gain or secondary agenda. It should, again, be a professional interpreter. Writing back and forth on keypads, notepads, texting, it's much, much cheaper than hiring an interpreter, but you're not getting the same information. And it's not fair to do to the client. This is something where, think about going to your doctor with a notepad and writing back and forth, how you're feeling and conducting your examination that way. It's just not an efficient way to communicate. Gesturing, I mean, again, gesturing is not the same as sign language. Lip speech reading, there's a lot of problems. There's a lot of controversy with it. But if, clearly stated by the deaf person that this is what I want, I'm a speech lip reader, I don't know sign language, that's how I want to communicate. Yeah, that's okay because it's being asked for, but you shouldn't assume that the deaf person can read lips or read your lips. Deaf interpreters over the phone, on-site video remote interpreting are all kind of, legitimate, interpreting methods or roles. You really want to try to meet with the interpreter for the evaluation. Interpreters are not mental health professionals. Interpreters, they're not trained in psychological evaluation. So it really is something where it's good that you as the psychologist, you as the evaluator are providing some information about the roles and expectations so that the interpreter isn't influencing either with facial gestures or providing answers, even unintentionally. So you do want to meet and kind of talk with your interpreter. Doesn't have to be for hours and hours. I mean, it can be, 5 minutes before the evaluation is probably enough time to kind of work with that interpreter. Familiarize the clinician with the role of the interpreter, so you understanding what the interpreter is there, what are the limits, what can they do, what can they not do, and then familiarize the interpreter with the process of the evaluation. Sometimes interpreters get called to jobs and it just says evaluation or it doesn't really say anything. And so, kind of again, having that time to, this is what we're going to be doing. Here are the things I'm going to be asking about. These are the words that I'm going to be using. Gives the interpreter a little bit of time to kind of, okay, that's what I'm doing. It's also a good idea to let the interpreter have a few minutes with the deaf client. Again, not all deaf people sign the same way. They don't all have the same proficiency. So, it's good to let them kind of, okay, I know this person's signing style. Then that way I can do a better job with how I'm going to be interpreting both, English to ASL, ASL to English. Ideally, you want somebody with experience and training in interpreting for evaluations, but that's very, very rare. You can request it. When you request an interpreter, you can ask for somebody with those skills. Whether or not you can provide it, that's another issue. But again, you've done your job. You've done your due diligence. You've at least made the request, and you can say that you made this request. Just remember, interpreters, they're there just for communication. They should not be advising, making decisions, or answering for the deaf person. You should not be asking them to do that. You really shouldn't be asking interpreters about their opinions in terms of, can this deaf person sign this contract? That really is something that's not within their purview. They're there to simply, facilitate communication, and that's really the limitation to their role. Just, again, just kind of a, last minute kind of thing. One of the things that I would always encourage you to do is be very good at documenting, whether you're using an interpreter, whether you're doing this by yourself, is really, put down on paper into your report, what accommodations did you make? What did you do? What did you change? And why did you do it? And have some reason for it. Have some reason to back it up. Is there some evidence or support for why you made the choice to do it this way? And again, are you honest about it in your report? Is it something that you're forthcoming about? Yeah, I had to do this, and so the results should be interpreted with caution. That's okay, because you're saying what you did. Did you consult? And consultation is a great thing. I mean, you're all going to have my email. You can consult with me if you want to. But did you consult? Did you make the effort to do that? Who did you consult with? What did you consult about? And again, having that documented. I got 3 examples of this. I'm not going to go through them, but again, each one of them kind of looks at this a different way. One is about what somebody did with the test. One is about consultation, and one is about talking about the fact that there's not a lot of data, there's not a lot of normative information about testing. And I do this all the time. I mean, I always put in these little caveats and documentations because again, I want the reader to know what I did, and I want to be upfront and honest. So you can kind of look at these and get a feel for that. So just some final thoughts. I know we're out of time, but as we talk about competence and as we sort of look at, what do we mean by a competent evaluator or a competent evaluation? What is that? I mean, what do you need or what constitute adequate skills or competence to evaluate someone who's deaf? And how do you decide that? I mean, who gets to be the judge of that? And we don't really know. There's a lot of different theories. There are some people working on it. I'm working on it with some deaf psychologist colleagues. But what really is that? What do we mean by that adequacy, and how do you know if you have it? And so when we talk about, is there some type of credentialing that only certain credentialed psychologists or mental health professionals should be doing evaluations with the deaf? What would that credentialing look like? I mean, you obviously you have to have some type of language, some type of cultural component. How do you measure that? I mean, that's sort of where you get into how do you know if they've met that certification? And then lastly, something to consider, are clinicians without specialized training, are, who evaluate, people who are deaf, is there an ethical violation? I mean, our ethical standards are pretty clear, and that is something to kind of think about, before you, sort of accept a job doing an evaluation with a deaf person if you're not familiar with it. Just like with other types of ethnicities or languages, is there something where, again, I'm committing an ethical violation because I'm accepting and working with a client that I really don't have a good knowledge of? And is that, in a sense, malpractice? So that's it. I don't know if we have any time for questions, or I think we have a couple minutes left. I'm kind of looking at the what training or education would you recommend for clinicians to improve their competence in working with deaf individual? This is Sevda. Hi, Sevda. Yeah, I would. Again, it's very rare. I think it's something where you have to look at it and approach it both from a language and an evaluative process. And again, I'm focusing mostly on evaluation. You could substitute therapy if you wanted to, but you really have to look at, do I understand, the language? Do I understand the nuances of the language well enough to do this? Now, again, that doesn't mean that you have to be 100% proficient and fluent in American Sign Language. That's why there are interpreters. But you have to know how to use the interpreter. You have to know about, what are the language concerns that may even affect the interpreter's ability to give a good evaluation or a meaningful evaluation. I would say, again, there's not very many places where you can get this kind of training. Probably, unless you go to Gallaudet University or the Rochester Institute of Technology has a program for the deaf. National Technical Institute for the Deaf, they have a psychology. I think they have a postdoc program. But I would say, look for people who are doing this type of work. Look for people who are qualified, who are, published, who have done this work, and try to connect with them to get mentorship, to get consultation, to get training under them. We have an American Sign Language and Deaf Culture Club here at NSU. We have a clinic in our psychological services clinic for the deaf and hard of hearing. We're actually looking to staff it right now. So again, places like that have that emphasis. I mean, those are probably the places you want to go to try to get as much of that training as you can. So I would say kind of approaching it from, both of those kind of, perspective, both the language and the cultural perspective. And in fact, you could say it actually is three pieces. It's the psychology perspective, the language perspective, and the cultural perspective. Can you play? It's under the psychology services clinic here at NSU. It's the same clinic that we have, our school psychology, neuropsych. It's just one of the clinics is for the deaf and hard of hearing. It's not up and running yet. We're still looking at staffing it. So, if there are practicum opportunities in mental health programs, there's not very many, and probably at the practicum level, I don't know of any. There are places, and again, I don't know if they're formal practicum sites. You probably want to work that out with your training director. So, for example, in Fort Lauderdale, we have a place called the Center for Hearing and Communication. It's kind of North Broward County. They're not a formal practicum site. Actually, I think they are a formal practicum site for our counseling program. They're not for the psychology program, but that would be something where you could get volunteer hours. If you had a desire, you could always look at what are some deaf agencies in your area and talk with your training director about maybe setting up a practicum. So I think it would kind of if it's training you want, it's probably something where you're going to have to kind of do the reaching out, and you're going to kind of have to promote it and the importance of it, because there probably aren't many that exist. Internships tend to be a little bit more, because if again, I'm talking more about psychology, but psychology internships, a lot of time they'll list that they have a deaf and hard of hearing rotation. I know I can't remember the name of it, but the state hospital in Alabama actually has a very good deaf unit, and again, not for practicum, but for internship and postdoc. Those are places that you could look at where you could get some of that experience. Yeah, Morgantown, that's where the School for the Deaf is. Yeah, Broughton Hospital. Yeah, I mean, it's kind of looking up some of those places that do have, deaf units, that do have, some services for the deaf. And by the way, I think on the last slide is my email. Feel free to email me with any questions you might have or to follow up. I'm perfectly happy to get emails.
Thank you so much, Dr. Feldman. I will now go ahead and end the meeting. Thank you, everyone, for attending.
All right. Thank you, everyone.